Hey guys, today we're going to be covering Chapter 28, Bleeding and Soft Tissue Trauma. In this chapter we'll go over various external and internal bleeding and factors that could potentially increase it. We'll go over hemorrhagic shock, various types of soft tissue trauma, closed and open soft tissue injuries, as well as go over various types of dressings and bandages. During this lesson you'll learn about bleeding and shock. Severe bleeding, if it is found, is controlled within your primary assessment because we want to try to stop that life-threatening emergency. Most other injuries are cared for after the primary assessment, and being able to recognize shock is an important element of our care. When dealing with any type of external bleed, the primary thing is standard precautions. You want to make sure that you are protecting yourself from potentially being exposed to the patient's blood. So whether it's make sure that you have gloves, gloves, mask, goggles, and gown if needed. Bleeding from soft tissue injuries may look disproportionate from the extent of the injury. For example, relatively superficial injuries to the scalp can bleed a considerable amount because of how vascular the scalp is. The severity of the bleeding relative to the amount of blood lost depends on the patient. A 500 milliliter blood loss might not be as severe in a large patient as it would be in a child or small adult. An adult patient has 70 milliliters per kilogram of blood volume. Thus, an average-sized adult weighing 154 pounds, which is 70 kilograms. Thus, meaning that they have 4,900 milliliters or 4.9 liters of blood volume. So a loss of 15% of blood volume or more is considered significant and can lead to shock. In that 154-pound patient, a loss of 735 milliliters of blood can lead to shock. Infants and young children typically have 80 milliliters per kilogram of blood volume. Thus, a 22-pound infant, or 10 kilos, would have a total blood volume of 800 milliliters. A 15% blood loss would be 120 milliliters. A 200 milliliter blood loss in an average-sized adult would represent only a 4% blood loss, whereas a 200 milliliter blood loss in a 10 kilogram patient would represent nearly almost a 25% blood loss. Since judging the amount of blood loss on appearance alone is unreliable, it's better to assess the amount of blood loss based upon the presenting signs and symptoms. Additionally, internal bleeding does not show any external blood loss and therefore is not seen. Table 28-1 goes over various classes of hemorrhaging. This can assist you in determining the amount of blood loss, such as in phase 1. With less than 15% blood loss, you may have an increased heart rate, increased vasoconstriction, slightly pale and cool skin, but blood pressure, ventilation, and pulse pressure is all normal. Whereas now when you get to that 15 to 30%, moving into class 2, your heart rate's even more increased. So now we're talking maybe 120, 130. Your pulse pressure is beginning to narrow. Ventilations are beginning to increase. Stage 3, now your pulse is even higher. Systolic blood pressure is starting to drop. Pulse pressure is beginning to become even more narrow. So having a knowledge of this material is very important. There's also various types of bleeding, depending if it's arterial, venous, or capillary. With an arterial bleed, you'll see bright red spurting blood from a wound, usually indicating a severed or damaged artery. It'll be pulsating with the beat. With a venous bleed, it'll be a darkish reddish color because this blood is deoxygenated. It'll be a steady, slow flow. With a capillary bleed, it's even slower and almost like an oozy type bleed. And remember that there may be a mixture of bleeding, as soft tissue trauma can easily result in simultaneous bleeding of arteries, veins, as well as capillary beds. To control it, we want to use whether it's direct pressure, tourniquets, splints, and topical hemostatic agents. Direct pressure will be taking gauze and directly placing pressure onto the injury, just like you do in your bleeding wounds and shock. Tourniquets, we want to place this above the injury, approximately about an inch above the injury. If we can't use a tourniquet, we want to consider using a hemostatic agent. If we have multiple patients, such as a mass cast situation, we want to skip step 1 and 2 and go straight to step 3. First method for controlling bleeding is direct pressure, usually accomplished by just placing a sterile gauze pad or dressing over the injury site and applying fingertip pressure directly to the point of bleeding. If severe bleeding persists while direct pressure is applied over dressings, remove the dressings and apply direct pressure to the point of bleeding, typically directly to a blood vessel. If they have an impaled object, we do not want to apply pressure to it due to the risk of potentially causing further extenuation of the injury. If you have an injury to the forearm, apply that fingertip pressure. If it still continues to bleed, apply direct pressure with your gloved fingertips to that point of bleeding. If they have large gaping wounds, pack these with sterile gauze and continue to apply that direct pressure. If bleeding to an extremity is not controlled with direct pressure, the next step is to apply a tourniquet. Commercial tourniquets are recommended. However, there are no contraindications to the application of it. You can make your own if needed. The first thing we want to do before application of a tourniquet is to attempt direct pressure. But if that does not work and the wound continues to bleed, we may then apply that tourniquet. When applying a tourniquet, we do not want to apply it over a joint, because if that patient begins to move their arm, it could cause that tourniquet to become dislodged. After application of the tourniquet, you also want to write the time of application on a piece of tape and apply it to the tourniquet, leaving it exposed to view and notifying the receiving facility that a tourniquet has been applied. If I have an injury to a spot such as here, we may need to apply what's called a junctional tourniquet. For this, they would that type of tourniquet would actually go directly over the injury and apply pressure to the junction or to the joint, so that way now we could potentially stop bleeding. This isn't something that we have in our area, but it is something potentially that could be coming into our region in the near future. Bleeding can be life-threatening in an extremity with a suspected fracture. If left unsplinted, movement of broken bone ends or bone fragments can continue to damage surrounding tissues and blood vessels. Also, movement of the extremity can cause any clots that have formed to be broken, which enables the vessels to continue bleeding. Apply splints on scene to extremity fractures only if the patient is stable and there are no other life-threatening conditions. If the patient is unstable, has any other life-threatening conditions, or exhibits signs of hemorrhagic shock, place the patient on a backboard or vacuum mattress and align the extremity fractures and begin rapid transport. Hemostatic agents are designed to improve clotting and control life-threatening hemorrhages that can't be controlled with direct pressures. The hemostatic impregnated gauze, dressing, or sponge is recommended because it can be packed into the wound. These agents are used for bleeding that cannot be controlled with direct pressure in wounds to areas of the body where a tourniquet cannot be applied. Now, junctional areas are where the extremities and head meet the torso. This is where traditional tourniquets cannot be used. These are used by the military for these types of injuries, but have not yet been approved for use in EMS. When approaching a scene with any kind of external bleeding, the first thing you want to do is take a scene size up. Ensure that the scene is safe. Form a general impression, noting any signs of shock or presence of significant bleeding. Try to determine the number of patients as well as any additional resources that might be needed. Move into your primary assessment. Make sure that your airway and breathing is intact. Assess whether the breathing rate and tidal volume to determine whether breathing is adequate. Assess for adequate oxygenation. If breathing is adequate and the patient exhibits signs and symptoms of poor perfusion, administer a high concentration of oxygen. This is an early and necessary emergency care procedure for shock and for blood loss. If the breathing is inadequate, begin positive pressure ventilation with supplemental oxygen attached to the ventilation device. Assess central and peripheral pulses, skin, and capillary refill. Make sure that you control any major bleeding that you find, but do not let dramatic injuries distract you from your primary assessment. After your primary assessment, you want to perform a rapid secondary assessment in any patient that has undergone significant bleeding, altered mental status, presents with multiple injuries, or has suffered a significant mechanism of injury. Your rapid secondary assessment can reveal any further potential life threats and provide further information about stages of shock. Because bleeding is a serious condition, the rapid secondary assessment should not, if possible, take more than 90 seconds to perform. This is just going through doing that rapid secondary, looking for any major bleeding. Looking for those other injuries, such as going through basically doing DCAP BTLS. Go through, get your vital signs, and you want to get these for two reasons. One, your vitals indicate the seriousness of blood loss, and two, your vitals can be compared to a series of later vitals measurements to determine whether the patient's condition is deteriorating, remaining the same, or improving. Keep in mind that vital signs can be deceiving and may not indicate the seriousness of the patient's condition, especially in pediatrics. Also, make sure to assess signs of perfusion or hypoperfusion. If a traumatized patient is unstable, research has shown that oxygen should be provided to keep pulse ox readings at 95% and above. Try to control any bleeding with direct pressure. Immobilize any injured extremities, provide your care for shock, and reassess. Bleeding from the nose, ears, or mouth may indicate a variety of different things, such as trauma to the nose, skull injury, sinusitis, hypertension, esophageal disease, and even clotting disorders. Epistaxis, or a nosebleed, can result from injury, disease, or the environment. Usually this type of bleeding is more of an annoyance than a threat to life. However, in cases of extreme blood loss, hemorrhagic shock could potentially develop. If the patient has any type of head injury or suspected head injury, we do not want to try to attempt to control this bleeding. Just let it bleed. If you're concerned about it bleeding everywhere, you can loosely apply gauze to soak up the blood, but we do not want to try to actively control it. However, if it is not due to a head injury and you have a nosebleed, first step is have the patient sit up straight and tip their head forward. This way the blood is not able to run down the back of the throat and the patient risks aspirating on their blood. You then want to pinch the fleshy part of the nostrils together. This will allow it to clot. Apply an ice pack to the nose and cheek to cause vasoconstriction, and you want to keep it this way for approximately 10 minutes. You then want to instruct the patient not to blow their nose for the next 12 hours after bleeding has stopped to prevent the clots from reopening. Internal bleeding or bleeding within the body organs can result from either trauma or medical problems. With this, bleeding may not be obvious at first and can rapidly result in the death of the patient. Common sources of internal bleeding may involve injured organs, fractured extremities. Hematoma is a collection of blood that contains a significant amount of blood underneath the skin. So you want to look at your signs and symptoms to estimate your severity of blood loss. With internal bleeding, you want to make sure, after ensuring that the scene is safe, approach your patient. During your general impression, look for any obvious major external bleeding. If you find a major bleed, immediately control it with direct pressure. As you continue with the primary assessment, assess your patient's mental status. Decreasing mental status is a sign of both hypoxia and shock. As the patient continues to lose blood, their mental status will continue to deteriorate. Support any lost functions of the airway, breathing, or their ventilations. Make sure that you assess the pulses and look for skin and capillary refill. If the potential MOI and your general impression of the patient suggests internal bleeding, proceed to your rapid secondary assessment following your primary assessment. If there is evidence of contusions, abrasions, deformity, impact marks, swelling, or other trauma, treat the patient for internal bleeding. This is a priority patient, so thus you want to prepare for immediate transport after rapid secondary assessment and initial emergency care. Internal bleeding is not very visible and may not be easily detectable. In some patients, by the time obvious signs and symptoms are present, the pain may have lost a significant amount of blood. Watch for subtle signs and symptoms and changes in the patient's conditions. Internal bleeding may be more subtle. Encourage students to, so you want to make sure that you constantly assess and reassess your patient for findings that may suggest internal bleeding, such as tenderness, bleeding from an orifice, nausea, vomiting, anxiety, combativeness, weakness and dizziness, tachycardia, tachypnea, a positive orthostatic test or tilt test. Try to make sure that you maintain that stat of at least 95%. Initiate transport and consider calling for ALS. Factors that could potentially increase bleeding within the patient is movement, because as you continue to move, your pulse goes up, so it's pushing out more blood. Medications can cause it if the patient is on blood thinners. Low body temperature due to vasoconstriction. IV fluids, because it could cause dilution of blood, as well as removal and dressings and bandages, potentially pulling clots off. Hemorrhagic shock is shock that is caused by inadequate tissue perfusion. This is where, due to some type of blood loss, causing cells to become deprived of oxygen and nutrients and beginning to fail and die. Patients that are going through hemorrhagic shock, you want to make sure that you do a proper scene size up, go through your physical, and reassess the patient. Go through your signs and symptoms, look for any mental status changes, vital sign changes, dilated pupils, nausea, vomiting, thirst. Make sure that you maintain that your ABCs, If you have to open up the airway, open it. Control any external bleeding. Keep the patient supine and treat for shock, and transport the patient rapidly to an appropriate facility. Alright guys, we're going to take a break here. Get up, stretch your legs, use the restroom, get something to drink. We'll come back shortly and pick up with soft tissue trauma.